So I'll make a quick note here. I'll put this when I post it in the classroom. If there was anyone that I Googled it while we were just on our little break, if there's anyone that is was watched the first. What was that, Josh?
Oh, I'm trying to figure out how to mute my audio again. The kids are talking.
Oh, okay. Um, this recording should be good because I figured it out now. But the first recording for the first little bit, it'll be hard to see me because when you record to the cloud, it automatically records like whoever's talking as the biggest view. And that's what I've always done, but my I'm recording these directly to my computer. So that records it as whatever I see, and I had it in gallery view for the first little bit. So if you go back to watch that recording, I apologize. I'm just one of the views until the first 20 or 30 minutes are over, and then I fixed it to this view because Candace helped me. Buh, 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 buh. Okay, so your exam three is made, and it is exactly what I had told you guys it would be in class. It is 40% pharmacology, and then 15 or 30% uh, shock, and 30% from the CPR class. So that actually ends up being 20 questions on pharmacology, 15 on shock, and 15 on resuscitation, as it's called in the book, that chapter. Um, so just like I said with the previous exam, that's roughly representative of how big the chapters were in the actual book. The shock chapter is a little bit shorter than that, but I don't want to ask you too many questions about resuscitation, because we already did the whole class and the AHA exam on that. Um, so that's what the breakdown is. 50 questions, 20 on pharma, and then 15 on chapters 13 and 15 on chapter 14. Um, there's not a huge amount to review for this. I expect that we'll get out in less than 2 hours, depending on what we have for questions. Um, the first thing I'll say as a blanket for pharmacology, you need to know going into this exam the medications that we give as EMTs, the indications for those, the contraindications for those, and then what the intended effect is and the common side effects. So, just to start with an example, Josh, you missed this, but I'm big on blackboards, so this is my blackboard. I write a lot of things up there. Move my chair out of the way. You also missed brand new, not brand new, like literally brand new, but I just moved into this house a couple weeks ago, so nothing is set up the way that it should be. So we'll do an example to start with, and then I want to go through some other stuff. And if we have extra time at the end, we will go back to the rest of the medications that we give as EMTs, and we can do this layout again for each of them. But I want to start with one, epinephrine. So epinephrine, our generic name for it is epinephrine. I would say that we don't usually see a brand name for epinephrine, but I'll put on our common other ways that we see it are as EpiPen, which we know is a device. It's not just, a brand name for the medication. But EpiPen are others. There is a new kind of like EpiPen out there that we're starting to see more and more, and that device is called an OVQ. It's written like that, AUVI-Q. It does the same thing as an EpiPen. It's the same dosages, but an EpiPen we know we take our lateral thigh and we stab ourselves like that. An OVQ is electronic, so it's the size of a credit card. Um, it's the size of a credit card, so it's about that big. We just take it and we hold it against the leg. It has a little sensor to tell it when it's being held against something, and then it will like count down and then release a little spring-loaded needle. So you just hold it and it will say like injecting 3, 2, 1, and then you'll hear it go click, and then it'll stick into the leg and inject the medication. It's the same idea as the EpiPen. It just works a little bit differently, but they're becoming more and more common. I
I've
had
got
my
one
first
that
patient.
I'm sorry, Angus. I got one at Indian River. I'll bring it in on Monday so everybody can see it.
Awesome. Because I just a few weeks ago had my first patient ever that had given themselves an OVQ before we got there. Um, so I got to experience that for the first time. These first started to exist actually when I was a lifeguard before I was in EMS, and they told us about them. And then they're just becoming more and more prevalent. People are seeing them. The other common name that we see for epinephrine that is not exactly a brand name, but and it's not a device, but that's epinephrine being referred to as adrenaline. So, like we had that little vial in class that said adrenaline on it, and then in the little tiny text underneath, it said epinephrine. So we do need to know that these two are the same thing. Um, just like we need to know that Viagra and sildenafil are the same thing. Um, okay, so we have our brand name. Our generic name is epinephrine. Then we need to know our indications for using epinephrine. So we know in EMS, our biggest one is always going to be anaphylaxis, which we know is just a severe allergic reaction. Severe allergic reactions, we're going to give epinephrine. Here in New York, we have a specific protocol that says, that sort of defines for us what a severe allergic reaction is. And we want to see those things before we give epi. Um, but in a general sense, our indications are anaphylaxis. And then our other one is severe respiratory distress. Remember, for us here in New York, giving an epi with severe respiratory distress, we need to call. We need to make the phone call and say, hey, I have a patient, really bad wheezing. We've done the nebulizer, or like the nebulizer's going, but we're still hitting saturations in the 80s. And I think that they could use some epinephrine. And the doctor says to us, yes, give epinephrine, and my name is Dr. Constantinopoulos. That's one of our doctors in Potsdam. Um, Remember when we get our med control orders, like RJ and I said, we always want to have who gave the order, not just the doctor, but Dr. Morgan, Dr. Constantinopoulos, Dr. whatever. We want to know who, in fact, it was that gave us that order. These are our two indications at the BLS level for when we're going to give epinephrine. All right. Our contraindications, I'll just put our contras here. I only said one in class, and it's sort of a relative one. It's something to think about, but it's not always a contraindication. Any of the three that are here remember what that was?
Wasn't it bleeding?
It's not
Or high heart
bleeding.
rate.
Bleeding's in our ABCs, so we always control bleeding in the ABCs. if it's a real problem. If it's like a paper cut, then we're not even thinking about it. What was it you had said, Josh?
Was it a high heart rate?
High heart rate. So one of the things we want to think about at least is tachycardia. Not necessarily, oh, my patient's heart rate is 103. So I'm not going to give it because Angus said that tachycardia is a contraindication. It's more along the lines of, okay, my patient's heart rate is like 150, 160. I know one of the side effects for giving epinephrine is that it's going to increase their heart rate. Maybe I should pause and think, or maybe I should call and get a doctor's advice on this before I give this medication. Um, Anyone that is having an anaphylactic reaction is probably already going to be a little tachycardic because it causes a lot of anxiety, especially if they're going into shock. But if they're crazy high heart rate, that 150, 160, then it's probably worth making the phone call. And I would reach to say that as a BLS provider, I would never flat out say their heart rate is too fast, I'm not giving epi. I would either say, okay, I'm going to give epi, or their heart rate is high enough that I'm going to call and ask if I should give epi. I would never say to just flat out not do it. Just if the heart rate is hitting that 150s, 160s range, I'd probably make the phone call and say, should I do this? This is already super fast. And I would bet that the doctors are going to tell you yes, but it's worth making the call. Candace?
So in the case of anaphylaxis caused by exercise, which seems to be this new thing, would you still would you just call the doctor? Because in most cases it would be safe to assume, I would think in that case, that the heart rate would naturally be much higher if people are exercising and having a reaction.
So when adults exercise, because if they've started to have this reaction and then they called, hopefully at least by the time they called 911, they've stopped exercising.
Right.
And then by the time we get there, someone even 2, 3 minutes that has stopped exercising 2, 3 minutes ago, even if their body is still like they're still recovering from that exercise, they shouldn't, for an adult, be hanging out in the 150, 160 range of heart rate. That is very high to be 3, 4, 5 minutes normal ambulance response time after exercise. And if it is still hanging that high, then I would probably say the same thing where maybe I'd just call the doctor and get their opinion on it.
All right. Thank you. Do you see that often? Anaphylaxis from exercise? No.
Asthma, certainly.
Right.
Anaphylaxis, no, I've never seen it, in fact.
Right.
But certainly asthma, a lot of nebulizers for exercise to induce asthma. But I've never had to give epi to someone for difficulty breathing secondary to exercise.
Thank you.
Oh my gosh. Speak of the devil. I want to cover this up so I don't break any HIPAA. But I just got it went away. I just got a page for allergies. Someone's having an anaphylactic reaction here in Potsdam. So crazy coinky dink. Okay. So we have our brand name, we have our indications, we have our contraindications. Next thing I would say would be our dose and our route. And I like to pair these together. So our dose for epinephrine is always 0.3 milligrams for an adult and 0.15 milligrams for a pediatric patient, for a child. Excuse me. And then we always give our epinephrine intramuscular. So I'm going to put IM. So 0.3 mgs for an adult, 0.15 mgs for a ped, and we always give it intramuscular. Now, if the patient has their own EpiPen, then we can give them their EpiPen. I usually save the EpiPen. If I'm going to an allergic reaction call, one of the things I'll often do is I would grab my check and inject kit and put it in my pocket before I even got on scene. Um, so that I already had it there with me. And I can have that medication drawn up and in, usually just as fast as they can have the EpiPen dug out of the bottom of the purse or the backpack, wherever it is. All right. Brand name, indications, contraindications, dose/route. And then
Angus, did you say there was two contraindications?
nope, I can't think of any other contraindications for epinephrine. Now, the contraindication we always have for any medication is an allergy. Um, but like I think you were the one that asked me about this in class, Josh. Epinephrine is a normal hormone that exists inside our body. So we wouldn't expect that someone would have an allergic reaction to epinephrine itself. If someone says, I'm allergic to EpiPens or something like that, they probably mean they're allergic to whatever like filler is in the medication. So when we give epinephrine, we're not giving pure epinephrine. We're giving epinephrine dissolved in saline. Um, so usually if someone's allergic to something that we know to be a natural hormone that exists inside their body, like if someone said, I'm allergic to insulin, um, then probably they're allergic to one of those fillers or binders that is given in the medication to make it shelf stable or to make it injectable, something like that.
Just in, the odd chance that you get somebody that's, says they're allergic to epinephrine or whatever, is there something else at the BS or the BLS level that we can give them?
We can give
Or
them nebulizers to help with the wheezing. Um, the other big question to ask there, and a question to ask anytime someone says they have an allergy to a medication, is what happens when you get that medication? Because, like I had said in class, a lot of times our patients have this list, even the hospital will have a list of allergies, and some of the things on there will actually be that the patient has adverse effects, and it might not be an anaphylactic allergy, where we need to be really concerned about their ability to live after giving this medication. So if you show up on scene and you've got a 14-year-old anaphylactic reaction to, something she ate at the barbecue, like we had last class with our shock scenarios, and the mom says she's allergic to EpiPens, that then you might follow up with what happens when she gets an EpiPen, because it might be she, had to have an EpiPen before, and she threw up, something like that. And in reality, you can live and throw up. You can't live and not breathe. So the doctor might have told them, tell EMS to give Benadryl, because paramedics can give Benadryl to help treat allergic reactions as well. But at the BLS level, if her reaction is stomach upset or vomiting, those are adverse effects, and we're more worried about getting her breathing better. And we can give her an emesis bag later if we need to, if she needs to throw up. So that's that always follow-up question to an allergy is what happens when you have that medication?
so basically you take the lesser of the two evils.
Absolutely. Yeah, it's always a balance for us in medicine. All right. So our intended effects. Our intended effects for epinephrine is one, to improve breathing. Now, I like when people remember epinephrine by remembering that it opens something and closes something else. So our intended effects for epinephrine are to improve breathing, and the goal is to improve it by dilating the bronchi. We know that dilate means take a tube and make it bigger. So the goal is to dilate the bronchi and constrict the vessels, blood vessels. I'm going to put BVs because I'm running out of blackboard here. So our intended effects are to dilate the bronchi and constrict the blood vessels. And as a result of that, what we're hoping will happen is we dilate the bronchi and their breathing gets better. We constrict the blood vessels and their blood pressure goes up. Our other effects that we know are going to happen, and they're not necessarily, in this case, I wouldn't even call them adverse effects, but they're other expected effects, are that we know that their heart rate is going to go up and that they're probably going to experience some anxiety, some restlessness, maybe some diaphoresis. We expect that that is going to happen. None of those are probably going to hurt them, but we should plan for the fact that they're going to happen. And we can warn our patients while we're sitting there giving them, the thigh massage after we inject the epinephrine. We can say, just so you know, you might start to feel jittery, you might start to feel anxious, things like that, to prepare them for this effect that's not intended. It's not a bad thing necessarily, but we know that it's going to happen. We know that their heart rate is going to go up.
So is this what they would consider like a bronchial dilator? Like you hear on some of the commercials, like
Absolutely.
albuterol.
Albuterol, epinephrine are both bronchodilators. Yep. We would include that in something I didn't write up here, which is its mechanism of action. So like I said in class, at the root level, when you look at mechanism of action, you tend to see a lot of big science words. So it'll say that epinephrine is a catecholamine that binds to the alpha and beta receptors. But at the BLS level, when we talk about mechanism of action, really I just want you to know, how does it reach these intended effects? So the intended effect of breathing and dilating the bronchi happens because it dilates the bronchioles. The intended effect of increasing the blood pressure happens because it narrows the blood vessels. It constricts the blood vessels. That's the extent that I want you guys to really worry about mechanism of action. There is a lot more to learn about mechanism of action for our medications, but I don't want you to worry too much about the deep science of it. All right. Oof. All right. One of the things I want to do, I'm going to put up a quick list of medications that you can buy that like someone might have a prescription for that they buy over the counter, with their names, their generic names, and their brand names. And I want you guys to know at the very least what the purpose of these medications are. Why someone might take them, and maybe how they're going to interact with medications that we give as EMTs. So the first two that I'm going to put up here are ones that probably everybody's got in the medicine cabinet at their house somewhere. I can move this forward. That seems no different at all. So the first two are ibuprofen, and Tylenol. What are some of the ways that we see ibuprofen sold? Or shoot, I should have put acetaminophen here. I'm getting ahead of myself. What are some of the brand names that we see ibuprofen sold under?
Advil.
Advil. Advil's probably our biggest one. Advil is one of those names where ibuprofen has become, or Advil has become so widespread that a lot of people just say Advil and they don't even know that it's actually ibuprofen. They think of Advil being Advil and the other kinds of ibuprofen being different kinds of Advil. So Advil is definitely the biggest one to know for that one. What's another brand name that we see Advil sold under?
Motrin.
Motrin. That's definitely our second biggest one for ibuprofen is Motrin.
Now would like Equate is Walmart's version or whatever, but then they
Equate
put
is the Walmart brand. So Equate has ibuprofen. They also have acetaminophen. But yeah, that's Walmart's overall health brand. I think the Advil that I have, or the ibuprofen that I have, is actually Equate ibuprofen.
so that'd be something to be more observant about if you see like an Equate bottle or whatever to make sure it is actually what it
Yes.
is.
Absolutely. All right, another one of the ones that we see, and it has other things in it, but it's a good one to know that it can be part of it. Well, this is under my next one, actually. Sorry. So these are the two that I would tell you to know for ibuprofen, Advil and Motrin. There are other names for sure. There are also always going to be things that like have ibuprofen as a component of them, but it's not the main thing. So like when we talk about the two of these together, Tylenol makes a Tylenol, it's called Tylenol dual action. And it actually is ibuprofen and acetaminophen in one pill together. And that's called Tylenol dual action. So our other names for acetaminophen, I gave one of them away earlier, so I'll put it up here, is Tylenol. Tylenol, just like Advil, has become such a pervasive name that a lot of people just know Tylenol as the name and not even, they don't think of it as acetaminophen. What are some other names for acetaminophen, other brands that we see it sold under? So there's a few, and they all come with little caveats to them. So one of them that I'll put on here is Midol. Midol is a medication for menstrual cramps, and it has other stuff in it, but its biggest ingredient is acetaminophen to help with the pain from menstrual cramps. All right. Another one is Excedrin, Excedrin migraine. Excedrin is Tylenol and caffeine and another medication, I think, and aspirin. But once again, Tylenol is a component of it, so it's something that we need to be aware of.
Tech 3 as well.
Sorry?
Tech 3.
Tech 3. I've never heard of that one.
Well, it's usually has caffeine, Tylenol, and I don't know what else does it have in it. Gets you nice and high. One sec. Usually sold for like $2 on the street, but there's prescribed as well. Tech 3. I don't take a lot of drugs anymore, so.
Oh, this is like the
One sec.
it's Tylenol mixed with codeine and maybe
Yeah,
something.
but then it also has caffeine, and sometimes it has other things in it, depending
Yeah.
on what brand it is. But
Yep.
yeah,
Not exactly a brand name, but outside the US, acetaminophen is usually called paracetamol. That's not a brand, that's considered the generic name in other countries. But you might see that, or you might interact with a patient who saw paracetamol as the name on a bottle somewhere, and they took it, and it's the exact same thing as acetaminophen. It's just a different name.
Can you spell that for me?
Oh boy, I don't even know if I spelled it right up here.
is that just pure Tylenol, or is it a mix?
No, it's not a mix. It's just the name for acetaminophen in other countries.
Okay, thank you.
It's actually paracetamol, so I did spell it wrong. All right, ready, Josh? Here we go together. Paracetamol. Paracetamol. Paracetamol.
Thank you.
You can look up how these names come to exist, but basically, like RJ said, there is a chemical name for every medication. And then that name is created by the scientists who create it. Generic names are approved by the World Health Organization. So most generic names are the same across countries. Brand names for a medication sold in the US have to be approved by the US Food and Drug Administration, but they may or may not be the same if you go other places.
So the chemical name is actually like C8H9NO2. Does that sound
For
right?
acetaminophen, there's an easy shortening of the chemical name, and
Okay.
it's APAP, APAP. And I don't know what it means off the top of my head, but I can tell you. So acetaminophen, the chemical name for it is N-acetyl P-aminophenol, and they take the A from acetyl, the P, and then the A from amino, and the P from phenol, and they call it APAP.
Awesome, thank you.
Yep.
Now, I know like NyQuil has acetaminophen in it too.
Absolutely. NyQuil and
would-
Dayquil both do.
That wouldn't be just like a generic name because it has that in it, or is that just the
It'd be
company
right along the
uses it
lines
in it?
with like Midol and Excedrin, where it has acetaminophen in it, and it's one of the components of something that has several medications in it. So in NyQuil and Dayquil, acetaminophen is there both as a pain reliever in case you have like body aches, and also as a fever suppressant. So acetaminophen helps pull your temperature down. So that's why it's in those two. But yeah. All right. And honestly, acetaminophen is just so widespread. We could fill this entire chalkboard writing way smaller than this with all the different brand name medications that have acetaminophen in them. If you see it on a test question, you're probably going to see it as acetaminophen, Tylenol, or Midol. And if it says what medication contains acetaminophen, it's probably going to be Excedrin. That's the example that JBL and the state like to use. of a medication that contains acetaminophen and other things. All right. Aspirin. Aspirin is an interesting one, and I'll throw in a little bit of backstory. Aspirin is a brand name. However, aspirin has existed for so long that the government took away Bayer Corp. Bayer is a pharmaceutical manufacturer. They used to have a trademark on the name aspirin. And the government took it away and basically said, so many people know aspirin as aspirin that we can't let you trademark it anymore. We need to let aspirin be the name that everyone uses. So now you can buy aspirin from Bayer, just like you used to be able to, the original like big manufacturer of it. But you can also buy medications called aspirin from Equate, the Walmart brand. And you can't do the same thing with these two because Advil and Tylenol are still trademarked. So you'll never see Equate Tylenol. You'll see Equate acetaminophen. And then sometimes in really little text beneath that, it'll say generic for Tylenol, something like that. But aspirin had their trademark taken away by the government because everyone just knew that as the medication name for so long.
So
To
it's
throw
kind of
in
like
my extra
Johnson
little
and
tidbit.
Johnson's.
What was that?
It's kind of like the company Johnson and Johnson,
Yeah.
where they have one product, that's known like talcum powder or whatever. That's the
Mhm.
actual thing, but they don't use the name for it or the company's name. They just call it what it is then.
Johnson and Johnson has had that happen to them several times, because I believe Johnson and Johnson also owns Band-Aid, and Band-Aid had their trademark taken away. Um, and then they haven't had their trademark taken away yet, but someday Kleenex could lose its trademark because we start to use Kleenex so pervasively now instead of tissue. Um, but for sure, aspirin. Just like I'll put it back up here, acetaminophen has the nice convenient APAP. Sometimes we'll see doctors and nurses write aspirin as ASA. Aspirin's chemical name is acetylsalicylic acid, if you can say it 10 times fast. Um, and a lot of times, if we're doing like an interfacility transport, we might get documentation from the hospital, and it might say that the patient was given 324 milligrams ASA, and that's aspirin. Um, Aspirin, because that name has lost its trademark, we don't have really any names like Advil or Motrin for it, but we do have, like with acetaminophen, a lot of medications that aspirin is a component of. So Excedrin is also has aspirin in it. Can I think of any others? Aspirin.
Is naproxen, that's part of acetaminophen, isn't it?
So naproxen is a different medication. That's a good one. I'll put that one up here as well. If I can one off the screen.
So there's
Naproxen.
some that are prescription only as well, right? Like Yosprala. I'm just reading this here. Um, Clopidogrel.
Clopidogrel.
Yeah.
That's the one that I mentioned in class. That's Plavix. It's another platelet inhibitor like aspirin.
Right. Obviously, I can't read English. Anacin.
I'm not familiar with that one.
Okay, it's over the counter. It says aspirin, acetaminophen. No, no, it has aspirin and caffeine. Maybe it looks like.
It's probably another any like over the counter migraine relief medication that you
Yeah.
see is going to be some combination usually of acetaminophen, aspirin, and caffeine. Usually
Okay,
the three, and those will be in any kind of generic migraine relief.
that makes sense.
Naproxen, that's a good one. I didn't think about that one. Naproxen has one big brand name, and it's really the only brand name it's sold under, and it's just about as famous now as Advil and Tylenol. Do you know what it is, Josh? You were the one that brought this up.
Aleve.
Aleve. Aleve is the big, big brand that made naproxen famous.
There's also one here with acetylsalicylic acid,
That's aspirin.
um, and clopidogrel. Is that what it's?
Clopidogrel.
Yeah.
So if you had a medication that was a mix of the two of them, that would
Yeah.
mean that it's just a really, really strong platelet inhibitor.
Okay.
Yep. Because Plavix and aspirin are our two main platelet inhibitors that our patients will take. So if they took a
Right.
medication that was a combination of the two, then it would just be a really, really, really strong platelet inhibitor.
Okay. Thank you.
So all of these fall into one bigger category, which is that they are all anti-inflammatory medications. All of these, that's how they treat pain. They all reduce inflammation in our body, which is why Advil and Tylenol and Aleve work really well when you have like a rolled ankle or when you just got out of surgery. Because the reason you have pain is because all these inflammatory markers are flying to your ankle or to your incision site, and they're by taking those medications, we tamp down that inflammation a little bit, and it helps us feel less pain from it. Other kinds of pain that we have, like people that have like neurologic pain, um, maybe they have like a pinched nerve in their arm and it causes painful tingling in their hand. A lot of them will find that these medications don't really help because they don't directly target pain centers, they target inflammation. And as a secondary effect of that, they also reduce pain. Um,
They would give like gabapentin for that, right? For nerve
Gabapentin is
pain.
definitely our most famous neurologic pain medication, for sure. That's a great point, Josh. Yep. These are all anti-inflammatories. Because of that, all of these also will have some amount of effect on a patient that has a fever. We definitely give acetaminophen as our biggest, most common fever control medication, but all of these are going to have some amount of effect on when you have a fever because they're all anti-inflammatory medications. All right. I'm going to take these off there and we're going to move into a different new group of over-the-counter slash prescribed medications that I think it's good for you guys to know. Obviously, as basics, other than aspirin, we don't administer ibuprofen, Tylenol, naproxen. We don't administer any of those. And we don't administer aspirin for like regular pain. We only administer aspirin for chest pain because when we use aspirin, we want to use it for its platelet properties and not for its anti-inflammatory properties. We don't give as basics any medications with the intention of reducing inflammation. All right.
I like how you use the red for the anti-inflammatory on there.
Yeah. This isn't going to be interesting to the recording people. This is a piece of chalk from like Walmart or something. I probably bought this at Walmart. This is the chalk that I use. They're different sizes, you can tell. This is called Hagoromo chalk. I order it from Japan, and it is the chalk that all mathematicians use. So you can see I have a big box of it here. Full Touch is one of the brands that sells Hagoromo chalk. It's very expensive. But if you hopefully notice, or it's easier to notice if you're here in the room with me, these are both red pieces of chalk. This is Hagoromo and this isn't. This chalk and this chalk provide, I did them both right in the glare, didn't I? Hagoromo chalk is much more full-bodied. It's a much finer powder that's compressed together, and it's wax coated. That's what that shininess is. It's wax coated.
That is so cool.
You can do cool stuff like this if you get really good with it. I haven't done that in a long time, and it's hard to see, but if you get good, you can make dotted lines just by pulling the chalk at a weird angle down the board. You can make dotted lines rather than going like that. Anyway, my chalk
Great
rant.
side note.
All right, some more medications that I want you guys to know from a different group. What else can we put up here? All right, there's a lot more on this list. What are all of these medications that I've put up here?
They are opiates.
They're all, I'm going to put opioid pain medications. So remember, in the previous group, they treated pain by targeting inflammatory responses, reducing inflammation, and sort of secondary as a coincidence, pain is reduced. These opioid medications directly inhibit what makes us feel pain. So they can help reduce pain for all different types of pain. There's a note I'll make based directly off something Josh said, and I'm glad you said it because I was going to make this note either way. Opiate versus opioid. Does anyone know the difference?
Is that how they affect the nerve receptors?
Not quite. Turn that off. Can you guys see anything with the light turned off now that it's the evening? No, not at all. I apologize for the glare. So,
Is one like more natural and one's like made from stuff under the kitchen sink, essentially?
yes.
Synthetic based.
Yep. So an opiate, the ATE form, comes directly from the poppy flower. It's derived from the poppy flower. An opioid is a synthetically created medication that we made mimic the structure of what we pull out of poppies, and we found also had analgesic effects. So fentanyl and both of these oxys are opioids. Morphine is an opiate. Morphine is directly derived from the stuff that comes out of the flower. Follow up on a similar point. Does anyone know the difference between oxycodone and OxyContin? So OxyContin, this guy is extended release. And oxycodone is immediate release. So usually we'll see that our patients that takes OxyContin look like they take a big dose of the medication because their bottle probably says take it, twice a day as needed for pain, at least 12 hours apart or something like that. And then oxycodone will probably be a smaller dose, and it'll say take 3-4 times a day as needed for pain, at least 4 hours apart, something like that. You can take oxycodone more often.
It'll usually say ER by the dose, won't it?
So that's where it gets weird. This is how it used to be, like flat out oxycodone was right now, OxyContin was long time. Now there are brands that make oxycodone ER for extended release. So sometimes you'll see oxycodones that get taken the same way OxyContin is. You'll also sometimes see morphine as morphine ER for, one morphine pill you take each day and it's supposed to last for 8, 10, 12 hours. Or you'll see morphine that's given, like in quick succession after each other. So like when we give morphine or fentanyl as paramedics, we give right now action morphine, but I can give more morphine a little bit later if I need to. One of the nice things about ER medications is one, it's less work that they have to worry about. You don't need to have the pill bottle with you. Also, we hope that it will stop an accidental overdose. If we say only take one of these per day, it should last you 12 hours, then hopefully they don't take too many. The flip side of that is that sometimes we have patients that take extended release medications. They take one, they wait a half an hour, nothing's happening. They take another one, they wait a half an hour, only a little bit is happening. They take a third. And now 2 hours from now, when you have 3 extended release tablets running at full blast, they're getting way too much opioid in their system. So always a good thing to note, though, if you see that ER on there, it usually means extended release. We also see patients that take, I think it's methylphenidate extended release. Methylphenidate ER, right? Yes. So like methylphenidate is a medication taken by patients that have ADHD usually. And then sometimes they'll take methylphenidate ER, where they just take one pill in the morning and they don't need to worry about it for the rest of the day. These are the main opioids I want you to know. There's a lot more, obviously. But these are, I would say, the main ones that you're going to see on exams.
They're
And
not gonna give us generic versions of these, are they? Or is there a generic version that's out there that we may possibly run into more
I
frequently?
don't think so. Most often, when we see different names for these, they are just the different ways that it's given. So, like, just like we have EpiPens and we have OVQs and they're the same medication, fentanyl comes as pills, it comes as patches. We can inject it if we're of that right level of care. Whereas some of these only come like, oxycodone and OxyContin, we almost always see as a pill.
No, just another quick question. Is there anything that we could administer as BLS that would have a reaction, would say if a patient has one of these patches on and they're incapacitated for better lack of the term, and we don't know that they have it, there's nothing that in our scope of practice that will interact with them, is there?
There's one, and it's the big one, it's Narcan. But other than that, no. The only medication that I can think of that would in our scope of practice that would interact with one of these would be obviously if someone gets Narcan, it's going to stop all of these from working because these are all opioids and Narcan's an opioid antagonist.
Okay, I wasn't sure because I know like certain things, like somebody that's ODing on say cocaine or something is already gonna have like a accelerated heart rate. They're gonna have tachycardia, and if they have anaphylactic shock over something, if you give them epi, that could be a real severe issue.
Nope, I can't think of anything because I can't really think of any medications that we give as basics that are depressants. And when we get to toxicology, we'll talk about this, but all of these opioids are depressants. They all bring our respiratory rate and our heart rate and our blood pressure down. So if we were going to have something that would negatively affect it, it would probably be if we were giving a medication that was also going to bring them down. And then we get that synergistic effect where they go way down. But almost all the medications we give are like uppers per se. They're all stimulants. Epi increases heart rate, increases blood pressure. Albuterol increases heart rate. Aspirin doesn't really have a big systemic effect of any kind. Narcan, obviously, I said is going to interact with these. Um, but no, I can't think of anything that would synergize the depression associated with opioid medications.
Okay, just something that clicked into my brain. Figured I
Absolutely.
better
No, it's
ask what I
great.
was
It's a very
thinking
good
about.
question for sure. Okay. Well, on that point, medications that interact with medications that we give. Sildenafil. What's the brand name?
You get Sudafed?
Nope. This is one that definitely interacts with something that we give and we talk. It's probably the one we talk about the most. I'm glad to hear, Josh, that you don't know what this is.
It's Viagra, isn't it?
It's Viagra. And then what about Tadalafil? We can see it's the same suffix, it's the same fill, so it's probably a related medication. What's the other most common erectile dysfunction medication that people take?
That's Cialis.
Yes.
Cialis. Yep.
Don't ask why I know all these.
Sildenafil and Tadalafil, or Tadalafil. Sorry, I'm checking. I keep checking my spelling on some of these. Tadalafil, Sildenafil and Tadalafil, Viagra and Cialis. So these are both for erectile dysfunction. But what's our concern with them? We're not concerned if our patients have erections. That's not something that's going to affect us, but something about these will.
Blood pressure.
Drop their blood pressure.
Yep. So these are now both, and I checked in your textbook to make sure, these are both now what we call relative contraindications. For nitro. These are relative contraindications for nitroglycerin. So what that means is if we have a patient and we're considering giving them nitro, if they have a Viagra prescription and they took Viagra 2 days ago, we're okay. Like we should be fine. If they have a Viagra prescription and they took Viagra 10 minutes ago, then it might be worth the call. This is another one where I'm not going to say 10 minutes ago, you don't give the medication. I'm going to say, if it was 10 minutes ago, you make the call and say, hey, I have a patient, take sildenafil. He just took one 10, 20 minutes ago, and then he started having crushing chest pain. He has a nitro script. I would like to give him nitro, but I wanted to check with you, Dr. Reed, first to see what you thought since he's just taken Viagra. He may say, well, are you able to administer fluids if the blood pressure comes down? To which the EMT would say, no. And then he might say, I would say, hold off. Remember that, and this is another thing about nitro. It's not necessarily about these medications, but it's a good piece to know. Remember that we give nitro as a pain relief medication. We don't give nitro necessarily hoping, we have research that actually proves this. The doses of nitro that we give and the frequencies they give, they're never going to be enough to reperfuse the heart. They're not going to fix a heart attack. What they are going to do is improve patient comfort. So when we give nitro, we're giving it as a pain medication. And like all pain medications, basically, it's come secondary to our ABCs. So if this Viagra Cialis is a concern and we call the doctor and the doctor says, I would hold off, then remember, not giving the nitro isn't going to hurt your patient directly, probably. We're giving it as a pain relief medication. And as long as the pain isn't so bad that their heart rate and blood pressure are getting even worse, it's not going to harm them. Because that's the other piece we're going to throw in there, right? I have a patient, 10 out of 10 crushing chest pain, took Viagra 20 minutes ago. I'd like to give him nitro. His blood pressure is, and then if you say his blood pressure is 125 over 68, then maybe the doctor would say, yeah, I'd hold off. That blood pressure meets your criteria, but it's so close to not meeting your criteria that I don't want to risk the synergistic effects. On the flip side, if the patient's blood pressure is 190 over 125, then the doctor might say, we got room to play in that, there's a long distance between where he is and being dangerously low. Go ahead, give the nitro. But I would, at the BLS level, that's a call that I would make to the doctor. If it's, probably anything over than 6 hours ago, then I would say, make sure it meets your New York State criteria, heart, blood pressure over 120, and then you should be good. And remember, with these crushing chest pain patients, we're probably at least making the request for ALS. I don't want you guys to think of everything as just call ALS and they'll handle it, because they might never come, but it never hurts to ask. Okay? That's all I have about.
Oh, sorry.
Oh, go ahead, Candace.
With these, from my understanding, at least my experience, which is, I'd say, quite plentiful, the Viagra is something that you would take sort of as a one-off thing, and a lot of people have Cialis where they take like daily.
Every day.
That's just my understanding between kind of the two, but I don't know if that's sort of a set thing or it's just the people I've happened to run into. But
It's not always set, but that is the general trend. You take a Viagra to promote an erection, and you
Right.
take Cialis to help promote your body's ability to have an erection when your body starts sending the natural hormones saying to develop an erection. But I would say, like, generally the same thing to be cautioned about with both, because they are in the same class of medications.
Makes sense. Thanks.
No, just a quick question on that. If a patient has taken Viagra or Cialis and had already administered a nitro themselves, because we can only assist with the nitro, it'd probably be a good idea to get ALS coming because of that particular scenario and the effects it could have.
That's a good scenario to get ALS coming. In reality, this group of calls where it's like severe, suspected cardiac related chest pain are going to be calls that we're asking for ALS. So, you'd probably be making the request anyway, but it's certainly an indicator to follow.
Now, with HIPAA and Scannerland out there, is there a better term when you grab the radio and call dispatch and I need ALS? Is there a because a statement to basically inform them that we could have a serious drop in blood pressure, maybe to something that when ALS is dispatched, they'll hear it and they'll kind of know without coming right out and saying, hey, this guy's got a problem going on before this problem,
Yeah.
kind of thing.
So I'll say that myself, when I get requested for ALS, I do appreciate when I know what I'm being requested for. If you just say, can you get ALS started this way? Dispatch doesn't usually follow up with why. Sometimes they do. I would say that for this, it's very easy to just say, I'm requesting ALS for cardiac monitoring. You could also say, I'm requesting ALS for hypotension. Even if they're not at that point yet, then they can, when they get there, if they're salty with you that the patient isn't yet hypotensive, then hopefully they can understand that the risk was there and that's why you requested them.
Hey, Angus, let me kick in real quick, Angus.
Yeah, go ahead, RJ.
Josh, I think that was an amazing question. And I appreciate that question because I've always told you guys to think 5 minutes down the road. What may happen 5 minutes from now? So you get there and the guy's like, things are going on. I took a Viagra, I took a Cialis, whatever. And then I had chest pain. I got nitro. I took one. So beautiful job, brother. You're like, okay, right now his blood pressure is 140 over whatever. We're good. But 5 minutes down the road, what might happen? What can I do? And I just want to commend you on your thought process and clinical reasoning on that, brother. Very good. Bravo.
Thank you, RJ. I just a question, could you say for a possible drug interaction or negative interaction, just this way they know that it's not just our BLS doesn't want to do their job. There's actually, a threat to life possible with this.
I would say that like saying a potential drug interaction might not be the best option because the other providers out there, when they hear drug interaction, are probably going to think like opioid or prescription med interaction, probably not along these lines. It's another thing worth knowing. Remember, when we request ALS, that we should generally know what we're requesting them for. And if this patient had crushing chest pain, but you gave them a nitro and it was working fine, there was no hypotension, whatever, you're probably going to be requesting ALS for cardiac monitoring. You want to put the stickers on and see what the 12 lead looks like, maybe. And this is something that used to happen to us in Potsdam all the time. You need in New York either a critical care or a paramedic to do that. An AEMT can't interpret a 12 lead. But think about in this situation, your concern isn't just the chest pain, your concern is for potential hypotension. An AEMT can administer fluids to help correct that hypotension if it might happen. So some of the times, one of the things you'll hear, this used to happen to us all the time in Potsdam, is Potsdam Rescue Norfolk Rescue is requesting ALS for cardiac monitoring. And then I get on the radio and I would say, I have an AEMT crew available. Would they like us to respond? Um, and that this is one of those situations where you get on your radio and you can say, yes, absolutely, I'd like you to respond because you can still fix at least one of the things that I'm concerned about. Regardless of whether or not this patient's having a heart attack, if their blood pressure goes low, it's a problem. And the AEMT can help with that.
Okay, thank you.
Is ALS typically requested over the radio? Wanting to be requested over the radio?
I didn't hear you, Logan. What was that? I'm sorry.
Typically, when you request for ALS, is it always over the radio, or are there situations where you can call dispatch, say landline, if the situation is private enough?
So you can always call. In terms of an ALS request, keep in mind that even if you call, dispatch might not then page the ALS agency and say landline dispatch. You might call and then dispatch airs the dirty laundry over the air anyway when they dispatch that agency out. But you certainly can always call. So that would be the situation, Josh, like when you said, is there another way I can communicate? You can get out the cell phone and call Central Dispatch and say, could you start ALS? I have a patient that has taken Viagra and nitro. But that doesn't guarantee that dispatch isn't then gonna get on the radio and say, Ogdensburg Rescue ALS, respond, intercept with Hewelton or I guess that's first responders, intercept with Morristown for a patient that took Viagra and nitro. And now it's aired out anyway. But you certainly can call.
Okay, I just wasn't sure with HIPAA if there was different things, when we're requesting for what we need.
So
No,
There's
because
a certain
no
way
matter
to
what,
request it.
you're never going to make the request including the patient's name or anything like that. So they should still remain protected.
and Josh, no, not for nothing, and excuse me, Angus, but
You're good.
not for nothing, Josh. This is why we want you guys to use medical terminology in your communications. Because when when instead of saying, hey, dispatch, can you send ALS because this guy, took nitro on top of his Viagra, right? Or you can say, dispatch, can you send me the next closest ALS? I have a potential case of what would be the side effect of that?
Hypotension.
Hypotension. So why not say that over the radio? One, you sound much more professional. Two, it doesn't give away any, craziness for people in scanner land, right? And three, it brings an air of confidence to your patient who may be sitting next to you doing all that, right? Because think from the view of the patient. You're sitting there having chest pain. You're gonna get on the radio and say, "Hey, dispatch, my patient took some Viagra and some nitro, and I need you over here." He's gonna hear you saying it over the radio. He doesn't know that that's a closed communication between you and whoever. He might think that this is going out to everywhere. So again, there's a reason why we say use your big science words. It goes a long way with sounding more confident and actually sound like the professional that you are. Make sense?
Yes, sir. Thank you.
All right. I think we beat this one to death. Let's move on to the next one.
Yeah, we'll move on. I want to do a quick like our flow chart for any time we give a medication, no matter the medication, how we go through that process. So obviously, before we give a medication, we always start, I'm going to move this over a little bit. We always start with an assessment because we don't really know that we need to give a medication until we've done our assessment. Now, like RJ and I have always said, your assessment really starts as the second your dispatch comes out. So sometimes your assessment is just, I get on scene, I get to the A of my ABCs, and in my A, I find out that they have a compromised airway from an allergic reaction. But still, we've done an assessment. You found out that compromised airway was there. So first step is always assessment, but that doesn't necessarily mean that we do all the primary and all the secondary before we get to our medications. Not necessarily in every case. Okay? 2, we pull out our medication. We confirm no allergies. This is one of the first things. I always start by asking my patients, like when I'm going to give a med, do you have any med allergies? And then I go into my patient education and I say, okay, I did my assessment. I think this person's in anaphylaxis. Do you have any medication allergies? They say no. And then I say, okay, I'm going to give you epinephrine. Now, the patient has the option here, in theory, to say, I don't like epinephrine. Whatever, some different situation probably. Maybe they say, I don't like nitro, it makes me dizzy. So I never take it. And then we can have a conversation about, well, I really think this nitro would help, blah, blah, blah. But this is that first little group. Because sometimes I say, do you have any allergies? They say no. And then I say, okay, I'd like to give you albuterol, or I'd like to give you albuterol and ipratropium. You might have heard of it called a Duoneb or Atrovent or something like that. And then they say, oh, I can't take Atrovent for XYZ reason. So I usually start with the generic, do you have any med allergies? And then during my patient education, where I tell them what I'm going to do, they might remember that they do have an allergy that I didn't know about. Sorry, got a little tossed over my words there. 4, that's when I'm going to confirm that I don't meet any of my contraindications. So like for albuterol, I don't have any big contraindications other than allergies. And from my assessment portion, I probably know that I want to give this medication. So when I say like, your assessment doesn't always need to be all the way through the secondary assessment before we can do this, the contraindications might tell you otherwise. So I get there, my patient says, oh, I have crushing chest pain, and they have a nitro prescription. Now, I can get through all these steps, but then when I get to contraindications, I realize, wait, I have a contraindication for nitroglycerin. I need to at least get a blood pressure before I give this med so I can complete this step number 4. Once I've confirmed there's no contraindications, I've talked to my patient about what they're going to get. My assessment tells me I should give it. Then I can go into my administration. Then I can give my med. However, maybe I'm going to give it. Sublingual for nitroglycerin, nebulizer for Duonebs, IM for epinephrine. However I'm going to do that, that's what I'm going to do in this step number 5. Step number 6. What's the first thing I do after I give a medication? Or what's the main thing I do after I give a medication?
Reassess.
Reassess. What am I looking for, Josh, in particular in my reassessment?
Any changes from your primary assessment the first time?
Any changes, but specific to medications, like with this reassessment after I give a med, what am I looking for when I do it?
Any changes to breathing or circulatory?
So basically, am I getting my intended effects? Is what I hoped would happen happening? Am I getting any adverse effects? Is there anything that's going, not what I was hoping for? I gave nitro and their chest pain is less, but now they also feel kind of dizzy. And then lastly, I'll use RJ's term here. Am I getting any untoward effects? So let's go back to our nitro example. My intended effect, reduced chest pain. They say my chest feels better, but I'm feeling a little dizzy. You can be dizzy and alive. Like it's okay to be dizzy. But then I recycle that blood pressure and now it's 70/40. So now I'm having an effect that is very not good. It's not just like oh, it's a little side effect. It's not clay colored stool. It's a potential for death. So those are those things that I'm looking for. Did I get my intended effect? And then is anything happening that maybe is annoying to the patient, but okay? And is anything happening that could maybe cause further harm in my patient? All right. That's my 6-step algorithm for giving meds. My roommate has a tablecloth thing on our dining room table, and it is completely covered in chalk. And I'm gonna have to wash it before she gets home tomorrow. She's in Buffalo right now. All right, I want to move on a little bit from pharmacology. Remember what I said at the beginning, that little thing we made for epinephrine? I want you guys to know all of those things for all of the medications in our scope. Epi, Narcan, albuterol, ipratropium, aspirin. I'm missing one, but I can't think of what it is. Whatever. Anyway, oxygen. I'm still missing one more. But I want to move on from that a little bit and go into
Say
shock.
Atrovent.
I said ipratropium because I'm cool.
Touche.
I don't know. I think that's it. Fun fact to go with all the rest of my fun facts. Ipratropium, that IUM at the end, the ium, that usually means that something is a salt of ammonia or an ammonium salt. Usually, that's what that means. Never going to see that on a test question, but fun thing to know. A lot of times when we see IUM at the end of it, that's why. Okay. So going into shock a little bit. Remember that shock really just means hypoperfusion. And the point of learning about shock is not really to tell when someone's in shock. It's to figure out what kind of shock they're in. Knowing that someone is hypoperfused is generally something that we can figure out quick in our assessment. We see the low blood pressure, maybe we see the mottled skin in late stages, maybe we see the peripheral cyanosis, blue fingers, blue lips, blue toes. All of that stuff points us to hypoperfusion. But hypoperfusion is not that useful to us knowing that they're hypoperfused if we don't know why to figure out if we can do something about it. Okay, so I'm going to start with our big overarching categories. And I'm going to leave the genic off the end of each of them because they're all genic. So cardiogenic shock, distributive shock, obstructive shock, and what am I missing? Cardiogenic, distributive, obstructive. Candace turned her camera off. This is normally where she helps me.
Is it neurologic?
Neurologic is a type of distributive. Oh my God. 7:30 p.m. All right. My brain's already turned off for the day.
Sorry, what are you asking about shock?
What's the fourth one that I'm missing? Cardiogenic, distributive, obstructive.
Distribute? No, you got that. Cardiogenic,
Septic?
obstructive.
Now I have obstructive. Septic is a type of distributive.
Hypovolemic.
Hypovolemic. Oh my God, the obvious one.
Those are all of them that I can think of.
No, these are the four. All our
Right.
other types of shock are subsidies of these.
Right. Okay.
So remember, there's three parts of the cardiovascular system. There's a pump, there's the tank and pipes, and there's the juice. So cardiogenic shock is a pump problem. Generally, it's that the pump is too weak. Now, there's different ways that that can manifest itself. Sometimes the pump is too weak because we're having an MI. And that infarction within the heart is killing the tissue. And without the tissue, we can't squeeze hard enough. Sometimes it's just weakened by time. And usually the way that manifests itself is that we have fluid backup. Generally as a component of CHF. So that's that example they give in your textbook where the fluid backs up into the lungs because the heart can't push hard enough to get the fluid out to the rest of the body. The left side of the heart is starting to fail. That's our pump problems. The heart is too weak and it can't push hard enough. Our distributive shock, the one that we have all these other types that fall under distributive shock. That's our tank. Tank. Usually, it's that the tank is too small. In general, when our tank becomes quote unquote too small, it's a subsidy of some kind of vasodilation. Our blood vessels open themselves up too much. And that's where all these subcategories come from. So, neurogenic shock, septic shock, anaphylactic shock. All of these come as a subsidy of distributive shock because they cause some amount of vasodilation throughout the body. And this is actually also where I didn't talk about it in class because it just doesn't get asked about a whole ton, but this is where our psychogenic shock comes in as well. The body gets very overworked, the blood vessels dilate as a result of, the nervous system response, and we end up in distributive shock. Psychogenic shock often is self-correcting. What might happen is they go into psychogenic shock, the blood pressure drops very rapidly, they might go completely unconscious, and then when they go unconscious, their nervous system comes down a little bit again. And then some of those shock symptoms revert themselves back to normal, and when they wake up, they are probably a little bit closer to their baseline and maybe not in that shocky area anymore. All right, obstructive shock is a pipe problem. The pipes are blocked. How we see this present itself is that we usually either have pneumothorax or hemothorax. These are really common abbreviations we use for those, PTX and HTX, pneumothorax and hemothorax.
Would we ever see those? Sorry, would we ever see those abbreviations on any testing in New York?
I will make sure that has not come up on your testing when I read through your tests. And if there was ever an abbreviation on your test like that you didn't know, then you could raise your hand. I would come over. Same thing for pretty much any abbreviation. If it says like AMS and you're having a brain fart, I'll come over and say altered mental status.
Thank you.
And also, Candace, just to clarify, like we said in the beginning, it's not. They're trying to get away from using abbreviations in narratives and documentation that's going to be widely distributed.
Right.
For because there are some times where you can have the same abbreviation could have three different meanings depending on who's reading it. So just something to keep in mind. But like Angus said, in testing, we'll try never to see it in there. If it slips by, it slips by, but we'll tell you. But we'll try never to put abbreviations.
Yeah.
Thank you.
All right. Pulmonary embolism and deep vein thrombosis. Those are both clots that can block the pipes of the system. And then for anyone that didn't come to or watch the exam 2 retake review that we did before this, we had a great conversation about pneumothoraces and the difference between open and closed and the difference between simple and tension. So even if you don't watch anything else in there, if you go to the probably a little after an hour mark, there's a great maybe 15-minute talk in there about pneumothorax and the difference between open and closed and the difference between simple and tension. And you get to see my art skills. So I'd recommend that to anyone, regardless of whether or not they're taking or retaking exam 2. All right, and then lastly, hypovolemic is our juice problem. And the problem is gone. Without juice, there's nothing for the heart to push on. There's nothing to fill the tanks. So obviously, anytime we have a hypovolemic one, the issue, like I put all these other underlying causes here, is that the fluid is gone. That can manifest in a lot of ways. Our biggest one is going to be too much stuff coming out the mouth, too much stuff coming out the butt, or you're bleeding. So excessive vomiting. And I'll throw in our medical term here. We call that hyperemesis. Too much vomiting. Excessive diarrhea. Now, really, any amount of like pooping, like someone could have pooped a lot and still be okay. It's very notable usually here that it's diarrhea, because remember that our intestines, as they process food, are supposed to pull out water from the food and send it to our circulation to be used as, fluid to help carry blood around. And when we eat or drink and we have too much water, we just urinate it out normally. Our kidneys process it out of the body. If we're having excessive diarrhea, that means that fluid is coming out more than it's going in, but also it means that fluid is probably coming out when it shouldn't be. There's probably a reason that all of this fluid is not being absorbed by our intestines the way that we normally would expect it to. So excessive diarrhea, wet bowel movements, and then the obvious one for all the trauma junkies, hemorrhage. If you bleed too much, you have less blood. These two are usually pretty treatable in EMS. Not always at the BLS level, but at the ALS level. The issue here isn't that they're out of blood cells. The issue is that there's not enough water to carry the blood cells around. And as AEMTs and paramedics, we can put more water right into the systemic circulation. That's not perfect. There's more stuff in blood than just water and blood cells. Lots of proteins and platelets and other stuff that goes into the plasma, but it's something that we can work on the way to the hospital.
With that said, is there anything, and this may sound like a complete rookie question, but is there anything that paramedics can do in terms of like injecting proteins into the body? Probably
Um,
not, right?
so here in New York these days, not really.
Okay.
In the national scope, paramedics can give thiamine, the banana bags.
Right.
And those have a lot more of that stuff in it. Also within the national scope, and not here in New York, but for annoying and dumb reasons, the more common fluid that we see given these days in the ER is called lactated ringers.
Okay.
And lactated ringers doesn't have proteins and that kind of stuff in it, but it has a much more diverse number of ions and nutrients in it. Whereas our saline that we give here in EMS is literally just sterile water with a very specific amount of salt added.
Thank you.
Lactated ringers has salt, it has potassium, it has glucose, it has a lot of these other good ions in it that are a little bit closer to the normal makeup of plasma.
Hey, Candace, that was an interesting question. What was your thought process behind asking if we can give protein?
That's an interesting question. I don't know, actually. I don't know. I guess I was just curious about just regenerative aspects of that's probably where I was focused. And like how water is held in the muscle after it goes through the blood and stuff like that. I think my head was kind of all over the place, but I was really just wondering what the scope of practice was and what options were available.
So, to answer your question and to back up what Angus said, and this is way above your pay grade for EMT, but water tends to follow albumin in the body. You know,
Right.
to the best of my knowledge, Angus, correct me if I'm wrong, but at our scope and at the paramedic level, there's nothing that we're gonna give that's gonna really add to albumin. We're always kind of chasing the dragon afterwards, after either the fluids have been pulled out of the interstitial spaces in the cells and being urinated out, or vice versa. It's being pulled into the interstitial spaces, causing edema and swelling in places where it shouldn't be there. But as far as protein, like Angus said, nothing there. So thank you. I was just curious what your thought process was.
I think some of it too was also weakness, like you see even in, let's say, drug addicts that have overdosed, or just people that are generally living sort of a weaker lifestyle. Just to get protein into the system is often important, and it's not always easy to do that. So just wondering how that all works. But
Yep.
now, relevant to that, just to touch on that. So you had said, not in New York specifically, but at the national level. So let's say you were a paramedic in New York and you had access to those, to say, what was it, thiamine?
Banana bags.
Yeah, let's
These
say
are
you
banana
have
bags. I looked at the picture. So, sorry, it's hard to see. That's a
Oh.
banana bag.
Okay,
So
cool.
it's basically saline or ringers as the like fluid component, and then it has thiamine, it has vitamin B, it has vitamin C, it has magnesium, and that's what's often given to patients that are in like alcohol withdrawal,
Right.
things like the specific things that you were mentioning. Sometimes there'll be Zofran mixed in with it to help with some of those withdrawal symptoms. Yeah.
So would you be allowed, let's say, I mean, would you technically be allowed to give that, or?
So, I would be, and RJ would be allowed to give thiamine if it was ordered on like an interfacility transport, but
Okay.
we wouldn't be able to give it, like, say we picked someone up at their house and they had thiamine, or they had banana bags because they have like a port and they do it every day for their cancer treatment.
Right.
We wouldn't be able to just do it. We could call and get an order for it, just like they could order it on a transport. But we need to be pretty careful with taking things like that a patient has at their house, things like that.
So
Fair.
I'm going. So I'm gonna just kind of cut this one short just because we're kind of getting way out above the
Right.
scope of the EMT and kind
Thank
of bring it back into what we need to do. But good questions.
Thank you.
Hemorrhage, this last one, as you know, within EMS around these parts, we try and fix hemorrhage the same way that we fix vomiting and diarrhea, which is we supplement it with other fluids that aren't blood. It's not a perfect fix. It's what we have, so it's what we do. But obviously, someone that has really severe hemorrhage needs blood. They need more blood to fix the blood that left, or to replace the blood that left. I'm going to leave our discussion of shock mostly with that. Um, Obviously, our treatment of shock we talked about very recently in class. Across the board, it's going to be keep warm, elevate legs, provide supplemental oxygen as needed. Um, and then we have our couple special cases. With our pulmonary edema patients, we usually want to use CPAP to try and correct the oxygenation issue. It's usually our best tool for that. With our tension pneumothorax patients, we obviously don't want to use CPAP. And then our one very, very treatable form of shock, anaphylaxis shock, we want to give epi. And other than that, we treat shock the best we can symptomatically. Like the example I gave in class, if we have a patient who's in shock and also is wheezing, then give them an albuterol treatment. We can still perform the rest of our scope as an EMT. But the treatment for shock directly across all the forms of shock is going to be that keep warm, elevate legs, supplemental oxygen as needed.
Just on a offshoot, Angus, you're
Yeah.
going over the drugs for BLS. I was going back through my notes. The one that we couldn't think of was oral glucose.
Oral glucose. Yep. That's another one that, like oral glucose and oxygen, they're absolutely medications, and we absolutely need to go through our same full checklist before we administer them. But they certainly have a lot less in the era of contraindications and like known adverse effects that we expect to see. They're a little bit lower, but we still all those steps for any of those meds, especially including oxygen.
Yeah, I just happened to be going through my notes for the shock, and I flipped past where I had wrote down the BLS pharmacology things from class, and it triggered my memory.
Awesome. In terms of resuscitation, our chapter 14, the last chapter on our exam. I'm just looking through my notes here, see what advice I can give in your studying on your own time for this chapter.
While Angus is doing his thing, there was a lot of great information done today. Angus, you did an amazing job.
Appreciate it.
With that being said, right, Angus and I have talked about this offline, and I will stand by this to the day I die. It is always beneficial to learn above the grade you practice. However, that being said, remember to you have to study on your own and glean what will be pertinent to our level of care. AKA, it's fantastic to know about lactated ringers, but at the EMT level, can we do anything with that? Not really. But as ALS support, we have an understanding, right? We know if I'm calling ALS for this, You may not say to the paramedic, "Hey, I think they need lactated ringers," but at least you have an understanding when the paramedic gets here what the process will be. Does that make sense? So when we start coming back for testing purposes, remember how to glean what's relevant to our scope out of what we've talked about. But everything Angus presented in this class has been fantastic.
Thank you. And I have to say, I don't know if you were chimed into the last one, RJ, but it was awesome. Like, just this whole 4 hours have been great. So I really appreciate it.
Okay. Come here.
Your assistant's helping. Yeah, what she said, I've taken a lot from this and actually realized how much I've retained from class and from reading. And it's going over it again is definitely making me feel more comfortable about it.
This stuff that we're doing here, that Angus and I are doing with these classes and these on our own time type things. This is why we said in the very, very beginning that there's a lot of onus on the student to study on their own, because there just really isn't uh, in the couple of months they give us to give you guys information. There's not a lot, and then don't forget we still have a whole nother world of hands-on practical skills that we have to address and get you guys proficient in. So please understand that when we offer times like this, it really is something to capitalize on.
Yep, I checked my email again. I did not have any other questions submitted by folks that couldn't be here. In terms of chapter 14, all I'm going to say is make sure you know your ratios, 30-2 for an adult and 15-2 for a child, only if two rescuers are present. Make sure we know our different airway maneuvers, specifically in cardiac arrest. We can do chin lifts, like the head tilt chin lift. We can do jaw thrusts. Make sure we know our different options for that. Know when to start CPR and when to stop CPR. For example, like if you're going to start CPR, make sure that it's still necessary. If we see that dependent lividity, injuries incompatible with life, they have a complete decapitation, then we know not to start CPR, and then know when the right times to stop CPR are. A MOLST is presented that says this goes against the patient's wishes. You have a physician's order to stop CPR, things like that. Know when to start, when to stop. Anything else? Keep in mind, chapter 14 also contains the choking stuff. We think about chapter 14 big about being about CPR and ventilating apneic patients. Chapter 14 also includes abdominal thrusts, chest thrusts for pregnant women, our infant algorithm for treating choking. Keep in mind that stuff is still also in there and it is covered on this exam. And then anything else in my notes? Sorry?
With CPR, is there a preference to whether like it being hands-on or if there's a Lucas available?
Oh, fantastic question, Logan. So, there is, but it comes on a few different fronts. There's a few things to consider. One, our research shows that the best CPR, the best compressions are performed by humans who know what they're doing. So that there's a big caveat on there. Certainly plenty of times that you walk in and there is someone who maybe was trained in bystander CPR years ago and their compressions just aren't deep enough or they just aren't fast enough. So we know that the best compressions are performed by humans who know how deep to go and at what rate. At the same time, we know that compressions performed by humans while we're moving a patient are hot garbage, and that compressions performed by a manual CPR device are much better when we're moving people because they can move with the person. So I would say that the best compressions are done by people, but depending on your crew size, depending on whether or not you're moving the patient, how much access you have to the patient. If the patient's between the bed and the wall, you have this much space to do compressions on me, and somehow you can get a Lucas board underneath me, then it might be better to do that because someone can't get on their knees next to me and do compressions. Um, Ideal situation, you have 15 firefighters, they all know exactly what they're doing, and you got plenty of space, plenty of time. Absolutely, I always have people do CPR. But as soon as we're going to move that patient, we switch to the mechanical. If there's only 2 or 3 people on scene and one of them needs to be ventilating, maybe I'm doing ALS stuff and that third person can't do compressions forever, I'll switch to the mechanical to reduce rescuer fatigue because we know that's going to make our compressions worse. All those things come into consideration. I rarely move my patients while they're in cardiac arrest, unless it's like an emergency move to get them to a place where I can start doing compressions right at the very beginning. And I usually work my arrests right there on scene until we get ROSC or we call it. So what I often do is when we get ROSC, I get the Lucas plate underneath them and I get the Lucas on it. So if we lose our circulation, it's there and ready to go because I know that it can do compressions better while we're moving and then once we get in the ambulance. But I don't usually stop CPR if I have enough people to put a Lucas on, unless they don't know what they're doing until I am ready to move the patient or something like that. Our research
Okay.
that people are number one.
Okay. Thank you.
So to piggyback on what Angus said, they don't cover it very well in the AHA or the Red Cross CPR class, but there's really nothing the hospital is going to do different uh, there than what that we're going to do at the paramedic level on scene with on scene with a patient in cardiac arrest. To be very honest, at the BLS level, you guys will do almost the same thing that we're going to do, with the exception of being able to administer fluids. The high quality compressions and the delivering of electricity at the appropriate times has the biggest impact on the patient's ability to survive a cardiac arrest. So I am not. I agree with Angus. I'm not one who I'm going to move unless I have to. And if I am going to do it, I will do the exact same thing Angus does. Hey, we got ROSC. We got an organized rhythm. Now I'm going to hang my other drugs. Put the Lucas on there. In the event we lose it again, because now I know I'll be moving on, moving in the ambulance.
The only last thing I'll mention about chapter 14, there is a question on your exam that asks about an impedance threshold device, an ITD. It is definitely covered in your textbook, but I didn't end up mentioning it in class. So check your textbook, make sure that you're familiar with an ITD. Right, wrote that right in the middle of the glare again. Make sure you're familiar with the ITD. You don't need to, like get one and use it. It's not like a crazy deep question, but make sure that you've read at least what it does, what the purpose of it is. All right. And then, yep, that's excuse me. That's really all I have to say about that, as Forrest Gump would say. I think Forrest Gump says that.
It absolutely was.
Any questions about anything? Second exam retake, third exam, things that we're covering in class in the upcoming week or so. Any questions at all?
Did we decide when we're gonna do the second retake for exam 2?
Yep. So we are going to offer them tomorrow before and after class, as well as on Thursday before and after class. And then outside of that, just send us a message if you would like a different time, and we will do our best to figure out a time that's more accommodating.
You mean
Okay.
Monday?
Sorry, what did I say?
You said tomorrow.
Oh, shoot. Yeah, we're not doing them tomorrow as far as I
So,
know.
so with that being said, understand that if you're looking for a time that's outside of the ones we have, it'll be completely dependent on our ability to accommodate that time. So if you ask for, Wednesday at, 1600, and I'm unable to get there and Angus is unable to get there, that may not be a possibility. So I strongly, strongly, strongly suggest you make arrangements to try to be either at the one or two times that we have here, because it's just that it's how we have it set up for structure. Because at the same time, we still have to uh, get everybody prepared for our next coming items. Does everybody understand? Does anybody
I
not
just want,
understand?
I just want to appreciate, let you guys know that it's very appreciated, all the extra you guys put into this. I know it means a lot to a bunch of us.
Yeah, well, I know not everybody appreciates it, so I really appreciate hearing that from you, Josh, because Angus and I, we really do spend a lot of time thinking about how we can offer more to you guys to get you guys to across the finish line.
Yes, it's
It
very
it definitely
appreciative.
shows.
Yeah, sincere thank you.
Now, the one thing that I like when during the lectures, especially, is when you're talking about something and then you give us like an example. When you say, you know, say we're talking about doing the Heimlich maneuver or whatever, just for an example, and say, this happened to me and this is how I recognize it and this is what I did. That when I'm sure it helps other people, but when I can like visualize, when you tell a story, you tell the steps and how it goes, that seems to help draw the process in for me, and then the steps become more clear because then I can, you know, mentally I can visualize the steps along with what's being taught. That seems to help me a lot when you guys do that.
Well, we'll try to keep that up there, Josh. So I think we're about to wind up, are we not, Angus?
I have one more point I'll stick in because you said that, Josh. This isn't a specific story, but one of the things we talked about in the review for the folks that are going to retake exam 2 was we talked about what drives respiration. And basically, we know it's not oxygen, because if you say it's oxygen, you're going to make mine and RJ's head explode. Um, but I'll stick this up here. CO2 is in our blood with water. And I have a feeling more people are going to watch this recording than the other one, so I want to stick this in there. Carbon dioxide also is not directly what drives respiration. Carbon dioxide mixes with water and it forms carbonic acid. And the word out of that I want you to see is acid. When CO2 and water mix, they form acid. That acid gets into our spinal fluid. And that is what tells our brain that it's time to breathe. Acid in the spinal fluid. Now, this is our normal process. This is our normal process by which that happens. We have exhaled, we're in between breaths, CO2 builds up in the blood, it mixes with water, forms carbonic acid, and that makes our spinal fluid acidic. However, all the other acids that might end up in our blood also make our spinal fluid acidic and tell our brain, hey, you need to breathe more. And that is why in DKA, we see those Kussmaul respirations that we call them, where they're very fast and very deep. The acid in DKA is coming from a totally different process than the acid that normally drives our respiration. But because it's acid, it still is telling our brain we need to breathe more. The point I want to make on this is when you have a patient in shock, watch their breathing. We have all these other fantastic indicators for what to do when a patient's in shock. You know, we have the hypotension, we have the fast heart rate, all of these other things. But one of the other things we mentioned in the previous review session tonight was that when we're not getting enough oxygen, when we're hypoperfused, our cells produce lactic acid. So when we go into shock, remember our definition of shock is hypoperfusion, our body will start to produce lactic acid, and that will drive our respiration the exact same way that the CO2 and the DKA drive our respiration by making our spinal fluid acidic. And every patient I've had that has been in severe shock, the breathing was the first thing I noticed, that they were starting to get what looked like a severe diabetic patient's breathing because they're starting to build up that acid inside their body. I don't know the heart rate until I palpate it. I don't know the blood pressure until I measure it. But I notice someone's breathing as soon as I walk up to them. And every severe shock patient I've ever had, this was the first thing that I noticed. They're breathing too much. And it's because they're building up lactic acid from not perfusing well. But that's a little tidbit. It's 8:17. I want to release you guys. If you have any other questions that come up later, please email me, email RJ, anything like that. When I taught math, I set up my computer like this plenty of times because someone emailed me a question and I recorded them a response and then emailed them back the recording because trying to write answers on what is going on in a math problem is very difficult to just type out in an email. So you may get a video response if you email me with a question, but we love when you guys ask. So if anything else comes up between now and the exam, please ask. And remember that we will be there early on Monday, at the very least at our normal time at 5 o'clock, or earlier if we end up having people that want to do their retakes on Monday. And if you have questions that you'd like answered before the exam, you can come in and see us then.
So I will be there by 4 o'clock on Monday. I strongly suggest try to get early as you can because the drop dead time will be the start of class. So if you come in at 5, understand you're only going to have an hour to do that test because we have to drop dead at 6. I will be there at 4. So if you think you require more time to take the exam, I strongly urge you to either come in at 4, just shoot me a text message, let me know you're going to be there so I can have a place for you to test and everything set up for you. If you're going to be there at 4, I strongly suggest you be there. That'll give you 2 hours to take the exam, or stay after class and then you can stay as long as you want. Okay? Does everybody understand that?
That's for those that are doing the retake on Monday.
Yes. Yep. So if you need more time, please, I'll be there by 4 o'clock for sure. Sometimes they're earlier, but text me if you plan on doing that early so I know and I can prepare for you to have a place to test. Because 1800 is the drop dead speed. We have to start class, or you can stay after class for as long as you want. I'll stay all night if I have to, so you guys can test.
Thank you.
All right, folks. If there's no last questions, I'm going to stop the recording. I appreciate the three of you attending in person. And for those that are watching this recording later, please email us with questions if you have them.
You said that Thursday was going to be the other retake day, right?
Thursday before and after class as well. Yes. And
Okay.
and just for RJ as well, most people that I've talked to thus far are planning to do Thursday so they don't take 2 exams in one night, which I can't blame them for.
Yeah, I can't blame him for that either. Sounds good.
Thank you.
Now,
All right.
with respect to the retake, you had said before after class on Monday as well. I guess we would have to tell you in advance.